Michael and Annie Mithoefer, welcome to Shrink Wrap Radio.
Thank you. Thanks for having us.
David.
Yeah, well, it's so good to have this opportunity to speak with you. As you know, my son, Jonathan Van Nuys, is training to be a medical trip sitter, and you were part of a workshop that you two offered in that program, and he raved about you both, and he insisted I had to have you on the show.
Well, we appreciate his enthusiasm.
We enjoyed having Jonathan too for the week. It was really nice to meet him. And
yeah, he's a sweet, sweet guy.
Yeah.
And I was also previously aware of your work through Tom Schroeder's excellent book, Acid Test. In a way, Acid Test is a misleading title for the book, I think, because it's about so much more, and it could be just dismissed based on the title. People could think to themselves, oh, I know all that Tim Leary stuff. And so that concerns me. And so I actually interviewed Tom about the book, I think about 4 years ago. And then, and I didn't remember, I was shocked to see how little I remembered, because I told Jonathan, because Jonathan was pressing me to listen to the audiobook version. I said, well, I interviewed him, but then as I listened to it again, I thought, wow, this all sounds new to me. But then I went back and read the transcript of my interview with him, and in fact, we had covered it all. So chalk it up to aging memory.
We know that one too.
Yeah, and also I found the YouTube of your presentation at the MAPS 2017 Psychedelic Science Conference in Oakland, and I wish I had seen you there. But it's wonderful that it's on video. Anybody can watch it. I encourage everybody who is listening or watching this. I'll put it's on YouTube. You can find it. Okay. So how many years now has it been that you two have been conducting research on psychedelic-assisted therapy?
Well, it's getting on toward 20 years since we started working on this.
Yeah.
Rick Doblin and I had our first conversation in January of 2000, and we agreed to work on this together. I was interested in doing psychedelic research, but didn't know if it would be possible, thinking maybe I'd have to go offshore. And Rick said, you can do it here and we'll help you.
Wow.
He said, why don't you go home and write a draft of a protocol for the first study, and then we'll start brainstorming about it. So that's when the process started. We actually got our first FDA permission for our first study in 2001, in November of 2001. And then it took until March of 2004 to get DEA and IRB, or Ethics Committee, approval. So we actually started the first study in early 2004.
Mm-hmm.
Yeah, and you guys, I love Tom's book. You know, you guys were such kids when you got the bug. Both Rick got the bug, and then you got the bug, and you guys traveled in the Caribbean. You were sailors, right?
Yeah.
So.
And did homeschooling and did that for almost 4 years. We came back some in the summer so Michael could work in the emergency room.
That was back when an ER doctor for 10 years before I went into psychiatry, which I didn't do until 91.
Uh-huh. Well, any couple that can stand sailing together for some period of time, small boat, that's a solid relationship together.
We had our moments, but it worked out.
Yeah. So what's your current role with MAPS? And why don't you also let people know what MAPS stands for? Not everybody might not know.
Mm-hmm.
Yeah, MAPS is the organization that Rick Doblin founded over 30 years ago. It's the Multidisciplinary Association for Psychedelic Studies. And it's a nonprofit, 501c3 nonprofit, and dedicated to bringing MDMA, other psychedelics, and cannabis through the regulatory process, by sponsoring good, solid research.
Yeah, and it's kind of a miracle that it exists, and that is doing as well as it has over the years, and has been able to sponsor You are now, I guess, in stage 3 or finishing up stage 3 of a 3-phase research process to ultimately get approval as a therapeutic modality.
Yeah,
Right.
we're kind of in the middle of phase 3. We're
Okay.
about just past the middle of the first phase 3 study, and then we've got to do another one right afterwards. But we're on the home stretch, hopefully.
Wow.
Well, yeah, Rick Doblin is perhaps the hardest working person I've ever known, and
Yeah.
incredibly dedicated, and the amount of work he has done to, not only organize this maps, but to raise the money for all this is remarkable. We've had no industry funding, no government funding. It's all money that MAPS has raised, mainly Rick has raised, but now there are other people helping him through private donations.
Mm-hmm.
I was amazed to hear that watching the YouTube, because I know it's incredibly expensive to do the sort of research that you're doing. It's labor intensive. It takes a lot of time, and I'm impressed by the care that you've brought to the structuring of it to make it as impeccable as possible. I was thinking this morning of the Don Juan books, and that was sort of a theme that I can't remember. It's been, what, 40 or 50 years since I read those.
Last time I read those too.
But something like the person of power must carry themselves impeccably. And that's the word that comes to mind as I look at this journey of research that you've been on to overcome the huge stigma that was attached to LSD, and then through a kind of negative halo effect spread to other psychedelics. So so good on you.
The only motivation is to help people, see if we can help people with this. So there's no financial motivation. Nobody's going to get rich from this being approved. So why would we do it any other way than as impeccably as we can to make sure we find out the truth? And also, we know that this is a controversial compound.
Mm-hmm.
And so we need to be extra rigorous in our research in order to see if we can get it approved, which we will be able to.
Yes, when you asked what we're doing now, what our roles are, my role mostly is supervisor for some of the therapy teams that are in phase 3. I don't supervise all of them because we have 2 other therapists in Boulder that also are therapists, and we're hoping to add some more therapists to our teams. But supervisors, yeah. And I also do the training with Michael. We do a lot of the training, and I'm on a lot of calls with MAPS, to organize the trainings and things like that. But it's mostly those 2 things I do.
Yeah. Well, I feel so privileged to be able to get this time with you guys, because I know how incredibly busy you both are. And Annie, since you were speaking, Jonathan had a question that he wanted me to specifically ask of you. You both have a nursing background.
I know.
Yeah, Jonathan and you. And so he wanted to know how that background maybe has impacted your approach as a psychedelic therapist.
Well, that's a really good question. I think, as far as nursing, the way nursing, I really like to think about nursing. It's sitting with people and talking to them about their lives and stories, and really the hands-on kind of care that a registered nurse used to do. I think it's more, that has become harder jobs with giving medicines and things like that. But so I love hospice work. I love being with people and just being in kind of deep conversation and process and caring for them. So I think that has been part of what I bring. Sometimes too much, you have to back off a little bit with, especially the male veterans who like to do things for themselves. But I think that's it. But I am drawn to deep processing too, which I don't think everybody is drawn to processing. Some people don't like to process much. So that's one of the things that's, I think, really a good thing about me. Yeah.
Yeah, well, that stands you in good stead for the work that you're doing, because you spend so much time with the people that you're working with, you know, days of a person maybe being tripping, and you're sitting there much of the time in silence.
That's
And
true.
I think I know that not everybody is cut out to do that. To
Yeah,
just be able to
that's
sit
true. I
there.
mean, I think the other thing about it is we use music, and I really love music, and I love putting together playlists and having that as part of the time that we're together, and
Yeah,
so that's also part of it. But
yeah. You know what you said about the impact of your nursing background really rings true to me, because I went to Jonathan's two graduations, one for his nursing degree and then nurse practitioner. Both
Mhm.
times I was so impressed by the faculty that got up and spoke, and the sort of, I have to use the word love. They were loving people with loving messages. And, you know, I went through a clinical psychology program a long time ago. I don't think the word love was ever mentioned in anything that was official.
It's
So,
true. And, we get in this kind of work, we had a very short amount of time to get to know people before we were going to guide them into something that, is not necessarily blissful. Ecstasy has that word ecstasy. A number of them said, I don't know why they call this ecstasy, because with PTSD, it can be, I mean, hard work, and so a lot of it is coming to love the person. I mean, really, for all the different parts of them, and ways that PTSD has kept them down. We don't necessarily always love our patients, but there is an element of that you become very fond of people in this, because you're so close to them in this
yeah.
intimate work.
Yes, yes. Well,
Mhm.
Michael, you're in the third stage, and it's involved not only the therapy that you two have been doing, but in the third stage, I think you've reached out to therapists in other countries, other universities, and so on. I wonder if you can, as you did in the MAPS conference in 2017, I think you were able to give kind of an overview of the effectiveness of this approach of psychedelic assisted psychotherapy. Um, can you, because, you know, from the statistics that you were able to present at that time, I think by uh, combining them, I think it came to about 100 and some cases.
Yeah, 105.
Okay.
Yeah, we've done since that first study that we started in 2004. There have now been 6 phase 2 studies of individual MDMA-assisted psychotherapy for PTSD. There have been some other ancillary things too, but those are the main studies going toward the FDA approval. And earlier this year we published the pooled results of the 6 phase 2 studies. Annie and I did 2 of those. One was in Boulder, Colorado, one was in Vancouver, one was in Switzerland, and one was in Israel. So they were different sites, different countries, different teams. And the pooled effect size was large compared to the one thing about our studies that's different from a lot of studies is our control group gets all the same psychotherapy. So it's a placebo control, or in some of these studies, it was a low dose kind of active placebo control. But everybody gets all the same intensive psychotherapy, including the all-day sessions, whether they're randomized to MDMA or to placebo. So we actually saw significant improvements in the placebo group due to all that therapy, but then the improvement in the MDMA group was much greater. So even comparing to the people that got all the therapy, our effect was much greater than well, the two drugs approved for PTSD now are Paxil and Zoloft, and our effect was twice that of Paxil and 3 times that of Zoloft. So
Yeah.
large effect size. And it was based on that data from those 6 phase 2 trials that the FDA gave us permission to go on to do what we're doing now, the phase 3 trials. And they also granted us breakthrough therapy designation, or granted MDMA-assisted psychotherapy breakthrough therapy designation, because the data was so promising and held the possibility of a big advance in the treatment of a life-threatening illness.
So what does that mean, that designation?
It means that the FDA feels that because of the strong effectiveness in phase 2 trials for a life-threatening problem, that they want to expedite the process of doing the phase 3 trials. So it means we still have to do the same phase 3 trials, but we have faster responses from FDA, more access. We can ask for meetings to discuss things that come up to try to move the thing along more quickly. So that's where we are now. We're doing phase 3 trials, and we have 14 sites in North America. 2 of those are in Canada. The rest are all over the U.S., Los Angeles, San Francisco, New York, Boston, Charleston, all around. And
are they all using MDMA?
Mm-hmm.
It's the same protocol in all these sites. It's a multi-site trial. And then we also have sites in Israel.
Okay. Now, there are other psychedelics that other people have advocated for in using the same approach, but a different psychedelic. What are the ones that other people are exploring, and why have you settled on MDMA?
Well, I think it's exciting that there's progress with a number of psychedelics. The one that's furthest along is psilocybin for depression, and that has breakthrough therapy designation with the FDA also now. So we're hopeful that both MDMA and PTSD and both MDMA for PTSD and psilocybin for depression will be moving through phase 3 in the next couple of years. There have been some other studies with ayahuasca. Of course, ketamine is a psychedelic that's already legal, so there's some studies with that, largely for depression, but beginning to look at other things. So I think, probably I would not be surprised if psilocybin also, or another psychedelic also was helpful for PTSD. But I do think there's something particularly well suited about MDMA for PTSD, because PTSD involves so much fear and anxiety and avoidance of painful emotions. And MDMA seems to really help with that. Again, I think many indications, once we get approval for one indication, it'll be much easier to study things for other indications.
Yeah.
Once psilocybin is approved, it'll be easier to study psilocybin for depression, for PTSD, once it's approved for depression. Psilocybin also has some really exciting studies about it, like nicotine addiction, smoking cessation.
Mm-hmm.
And also, we had, in our secondary measures, we saw big improvements in depression scores with MDMA. So I think that would be another logical thing to look at once we finish with the PTSD trials. There is an eating disorder, MDMA-assisted therapy for eating disorder study that's hopefully going to be starting soon. So, and I think one point is none of these are just studying MDMA. They're all studying MDMA-assisted psychotherapy. So it's kind of a different model from the usual drug trials or the usual psychotherapy trials. It's really a hybrid. We view the MDMA as a catalyst for the therapy. The actual therapeutic process at least largely, we think comes from the experience people have.
Right.
So there's also a direct chemical effect that helps to decrease anxiety and increase insight without interfering with memory. So it's an interesting combination.
Yeah. So what are the talk therapy modalities that you draw upon?
Well, that's an interesting question. We draw heavily upon our training with Stanislav Grof and Christina Grof, who,
Yep.
you know, Stan Grof, I'm sure you know, was an early LSD researcher. And we trained with Stan in holotropic breathwork, which is a non-drug method of supporting people in non-ordinary states. And it, you know, the way he teaches doing that brings a lot from his experience with LSD psychotherapy, which he had vast experience with in the past. So it's very heavily influenced by Stan's idea of the healing potential of non-ordinary states of consciousness, that if you can, in the right setting, with the right mindset and the preparation and support, if somebody enters a non-ordinary state of consciousness, which can be done with breathing, meditation, or with medicines like MDMA or other psychedelics, when people enter that state, there seems to be greater access to a kind of innate healing intelligence that Stan talks about it as if there's an inner radar that kind of goes to what needs to be processed at that time. So it's a very inner-directed approach in our minds. So,
or self-led or self-directed.
Yeah.
Mm-hmm.
So and relatively non-directive on the therapist side. So we want to make sure we follow, you know, encourage and follow someone's own natural healing process rather than directing it. Having said that, it doesn't mean we never give direction, and it doesn't mean we don't use tools from other approaches that we've learned and had experience with. So, you know, one nice thing about the non-directive approach is you find out sometimes people go directly to the trauma and do basically imaginal exposure, like they would with prolonged exposure therapy.
That just suddenly starts. Somebody
Yeah.
just right in the middle of the trauma and discussing it, telling us all about remembering things they couldn't remember before, little pieces that might have been blocked. So, you know, that would be an example of that.
I would expect that would be part of their set. And the case of working with PTSD, they know that's why they're there.
Exactly.
Yeah.
So some part of them says, okay, let's get down to it.
Right. And we always tell people that, you know, if they don't bring up the trauma, then we might gently ask them if it has come up or bring that up at an appropriate time. We don't push people to go right to the trauma, but like Michael said, some people will go right to the trauma, and some people will go to what their life looks like now and realize that they're actually safe now before they go into the traumatic material. So it's amazing how different the sessions can be for people.
Yeah.
Kind of spontaneously incorporates what what most therapists would recognize as parts of various therapeutic approaches. So they usually have imaginal exposure at some point. They almost always have some psychodynamic material that comes up. They talk about early childhood or family dynamics or relationships. They often spontaneously become aware of cognitive distortions and kind of see the distortion and correct them. There are elements of cognitive behavioral therapy that come in. People have some very powerful imagery sometimes that's very much like Jungian archetypal imagery.
Mm-hmm.
People can have transpersonal or spiritual experiences that can be profound. So our approach is to make space for any of those to support people appropriately according to what's coming up, but not to tell them when to do what.
Mm-hmm.
We encourage them to see what happens.
it's great that it sort of spontaneously supports these different theoretical perspectives. It's kind of like the old thing of the blind people and the elephant, you know, describing the elephant. And so
Yeah.
all these different theories seem to have tapped into an aspect of,
Uh-huh.
you know, the human experience and to kind of develop some piece of it. My previous interview was with Stephen Hayes, the originator of acceptance and commitment therapy.
Oh,
And,
right. Yeah.
and it seems like that could be a good fit as well. Is that something that you or others are drawing upon? Its roots are in CBT, cognitive behavioral therapy.
We've
But
had a couple of participants that actually had done that before, and it found it very useful for the sessions. Yeah.
yeah, interesting.
But you know, Michael also forgot to mention internal family systems, the IFS model.
Yes.
A lot of times the people will have more self will show up for them, where they
More self-energy.
Self-energy, where they might also see parts of their personality or ways that they're stuck in those extreme parts of their personality. So, I mean, those kinds of things all just automatically, just come up during the session, but then the way that you want to help people is how to integrate the material.
Right.
It comes up during that day long with, whatever form of therapy that you traditionally have used in your practice.
Yeah, I'm glad you mentioned that, because I'm trained in internal family systems therapy. I think it's extremely valuable and fits really well with this work, because, as Annie said, often people become aware and start talking about different parts of themselves, not as a pathological process, but as a normal phenomenon we become aware of.
Mm-hmm.
And we actually did a little sub-study informally and found that almost 70% of people with active doses of MDMA brought up something about parts, whereas with the placebo, it was less than 25% brought it up. So there does seem to be something about MDMA that helps people become more aware of this normal phenomenon that Dick Schwartz has so elegantly explored and developed in internal family systems therapy.
I wish he had named it something else, though, because
everybody
your family therapy systems, that brings up a whole different set of association.
Exactly, yeah.
You have to explain to people that it's not family therapy. Yeah.
Right.
We had lots of discussions in the community, IFS community, about that, but it's kind of hard to go back.
Yeah, right.
It's also interesting you mentioned the elephant, the blind people and the elephant, because I have a slide that I've used in quite a few talks with an elephant and making just the point you're making.
Yeah, all right. So
one other thing I think we just forgot to mention was also bringing in the somatic element of the work around PTSD, because very often people with PTSD have never experienced being relaxed and feeling good in their body. It's very foreign if people have had PTSD for 10 years, it's just not a place where they have been. And sometimes feeling good in their body too, So we pay a lot of attention to what's happening in the body. If someone has had a trauma that occurred someplace, like being stabbed or falling out of a Humvee or whatever, you might see things around them holding energy in that place in their body.
Mm-hmm. And so how do you deal with that? Is it, I gather, kind of a directing of their attention?
Mm-hmm, we do. It's partly what we've learned with our breathwork training, but having people focus on those places and putting energy, breathing into those places, and maybe exaggerating a pain that they had in that place. For instance, somebody who was stabbed, really imagining what is there, and then filling it in, having them fill it in with whatever's coming. Like they might have memories come and, around that spot.
And sometimes, because we're trained in doing body work in the holotropic breath work, we sometimes do some direct body work. Very often, just inviting somebody to notice what's happening in the body and breathe into it and let the body express itself is all that's needed. And for teams that aren't trained in other kinds of body work, that's really what we ask them to do. But sometimes, and we have some therapists that are trained in other, trained by Pat Ogden or trained by Peter Levine in somatic experiencing, and they use those skills in response to what's happening if things are coming up in the body. But the main thing, whatever the therapist's background, is to not leave out the body, to encourage people to pay attention, let it move, explore what's happening in the body.
Maybe I should have you take us through the basic setup of how the therapy is conducted. Is it a 3-day or how many days is it? Does that vary depending upon the person?
There are three. Yeah, there are 3 all-day sessions. Are the only time the MDMA is used, and they're a month apart. So it starts with first informed consent, of course, and then we do careful medical and psychological screening. We don't take people if they have serious illness, especially heart disease or cerebrovascular disease. But after the screening and the baseline measures and informed consent, then we have 3 preparatory sessions, which are 90 minutes each, in order to begin to get to know people and answer their questions, prepare them for the approach we're going to take. And as Annie said, that's a pretty short time to get to know somebody before you dive so deep. But it works because the MDMA helps, or even actually in the placebo sessions, people have valuable experience, because then the all-day sessions, what happens is people come usually at 9:30 in the morning, we meet with them a bit, and then we give them the MDMA or the placebo at 10, and then 2 therapists, in most cases male and female therapists, but always 2 therapists, spend the next 8 hours at least with people. Annie and I do it. We have a futon where people can either lean up against the wall on pillows or lie down. We have eye shades and headphones if people are comfortable with that. Not everyone is, so we don't require it, but it can help people focus inward. And then we invite them to go inside. Annie, in the case of our team, Annie does the music. If they want music, they can also ask to have quiet. And then the day just unfolds with alternating periods of inner focus, alternating with periods of talking to the therapist. And there's no schedule for that. We always check in with people about every hour, but if they're having a deep experience, it'll just be a brief check-in and maybe get them to drink, have something to drink and check their temperature, if it's time for that, for their blood pressure. And then just tell them they can come out and talk to us anytime. And then sometimes if people have been talking for a long time, we might get the sense it would be good to go back inside, and we'll say maybe this is a good time to go back inside. So I'd say on average it's probably about half and half, but there's a big range. Some people spend almost all the time inside and then tell us what happened later. Other people spend much more time talking, but we think it's both are important, both the talking and the time inside.
Yeah.
And then after that, then they spend the night.
In the afternoon, we give them a snack.
Yeah.
Yeah.
And then by around 5:30 is when the night attendant shows up. We usually leave not too long after that, although if there's still a lot of process, we stay as long as we need to. And then they spend the night in the clinic with the night attendant. In most of the sites, there are a couple sites where we're experimenting with not having them spend the night, but it's probably ideal that they can spend the night so they don't have to deal with the outside world. They can just stay with their process.
Mm-hmm.
And then we come back, the therapists come back the next morning and meet with them for 90 minutes before they go home. Then we talk to them every day on the phone for a week. Or now we're beginning to space that out a little more, but we have frequent phone check-ins afterwards, and we're on call 24 hours a day. Encourage them to call us if things are coming up that are difficult, because sometimes things are difficult the week afterwards. And then we have 2 more integration sessions, 90-minute sessions to help them integrate the experience before the next MDMA session. And then there's 2 more MDMA sessions. And then we have follow-up measures going out to a year.
Yeah.
Or in some cases, we've had them 3.5 years later.
Yeah. So one of the things that I know that you're interested in as well is scalability. Like, this is a lot of manpower, woman power, time involved in this. It would be very expensive for somebody to pay for it out of their pocket, even if possible. And so as you look down the road, do you have any ideas about how this, because the number of people who suffer from PTSD alone, setting aside a lot of the other psychological issues that need to be dealt with perhaps in a similar way, is huge. I'm not good at remembering all the numbers, but I know they're up into the hundreds of thousands or something like that. Any ideas about how to address it on a larger scale?
Well, we spend a lot of time discussing that these days, and we have some consultants, various kinds of consultants, kind of helping us work on that, including efforts already toward getting insurance companies to pay for it eventually. They're not going to do it right now, but so we're very concerned about that, about both affordability and scalability. Affordability, they're a bit separate. We think that this is probably a very cost-effective treatment in the long run.
Yeah.
But the upfront costs are more, and the logistics are different from what therapists are used to doing. So part of the approach to that is convince the insurance companies that it's worth paying for this, because it's going to save them money in the long run. And I think we'll be able to make that case as time goes on. Also, I think there will be ways to make it less expensive by, after approval, because probably, for some people, 8-hour session and 2 therapists is really important. For other people, they might be able to have a somewhat shorter session and go home if they have good support at home, and go home. We're also beginning to explore and design studies to look at group therapy. So I think there will, what we've done in the trials is do everything we can think of within reason to maximize safety and effectiveness.
Sure.
And again, for some people, I think this level of support and time will continue to be necessary, but there are probably a lot of other people that could do it either in a group or in somewhat shorter sessions. So that's that part. As far as scalability, that depends on training enough therapists, and that's a big challenge. So
right.
And what the kind of the choke point in the process is we need people people have to get experience doing this before they can train people, and they can only get experience doing this in clinical trials now, because that's the only legal way to do it, or at least legal experience. We're aware that there are underground therapists, and some of whom I think are doing wonderful work, and others, who knows. But as far as what's legal, we need to develop more training teams as people. The people that we've trained now are now working in the clinical trials, and they're gaining experience pretty quickly now. So there's a second training team now, Marcel and Bruce in Boulder, and we're thinking about what the next training team. So I think the bottleneck is going to begin to break up as people get more experience in the clinical
Yeah.
trial. We also need people who need supervision when they first, after they're trained. So we need to develop more supervisors, which we're already doing. We have a number of therapists that are in the phase 3 trials now that we're talking to about becoming supervisors. So, but it's still a daunting task to scale it as fast as we'd like to without losing quality. That's the big challenge. Where is the line between as much speed as we can get without losing quality?
Yeah, it's a knotty problem. I'm glad you mentioned the underground therapist, because in some ways the cat's out of the bag. I mean, there's a lot of stuff going on, you know, with people going to other countries to engage in 3-day workshops, a day of preparation, the day of taking the substance, a day of integration. And that's a model that's happening willy-nilly.
Yeah,
Right.
we've run into people who have done that and had some problems.
Really, yeah. There's a lot of marketing going on, you know, too, around all of that. And business and marketing people getting very interested, I think, in monetizing this sort of experience. So,
Yeah.
and I'm sure, you know, you've got to be very careful to preserve what you're doing. So yeah, time will tell. I guess is the only thing we can say.
Challenge for us at this stage. You know, we've been so focused on how do we do this studies well, and now we're called to focus on the next stage.
Yeah. Well, speaking of the stuff that's happening in the wild, do you have any observations or ideas about the microdosing phenomenon?
Well,
I know it's not part of the work that you're doing.
I talked to Jim Fadiman about it and read about it and known some people that have done it, and I'm not sure what to make of it. But it seems like an interesting phenomenon. You know, it's a different kind of model. Obviously, it's not the model of assisting psychotherapy, and it's not the model of only needing something a few times and then not needing it anymore. But it's an interesting thing. I think it would be good to actually, if somebody would do a controlled trial with it.
Yeah, hopefully, you know, that will be possible somewhere along the line on the heels of the approvals that you're able to get, and set a little bit of a precedent for at least doing some research on it, because it deserves to be researched.
Yeah, right.
And particularly since people are going to do things, you know, it would be nice if they could do it with some knowledge.
Yeah, it would be. And when you have, you know, well-trained and experienced people like Jim Fadiman talking about really helpful effects that he's seeing in his surveys, it certainly ought to be followed up with controlled research for sure.
Yeah, definitely. Let's see if I have anything else I wanted to. Presumably, we could talk endlessly about this stuff. But we've covered a lot of the ground that I wanted to cover. Set and setting, of course, is extremely important and is embedded in the work that you're doing. And
that's, I mean, I think that's really something to emphasize, because, you know, one of our concerns is that when people read about, oh, we're having these successful trials, they may not be aware of the importance of not only careful medical screening and psychological screening and well-trained therapists and built-in preparation and integration for a good set and setting. The results are, and the safety, I think, are highly dependent on those things. So it's very important that people not get the wrong idea.
Yeah, and it's not easy to get a safe. It's not easy to deliver safety unless you've got that sort of governmental shield that you have right now.
Right.
Otherwise, the police could break down the door any moment, and that's a vulnerable place to be out of your mind, so to speak.
Yes,
Is
yeah.
that
Yeah.
somewhere in the back of your mind?
Well,
And
I
also-
think one thing that Michael and I always have trouble conveying to people at the trainings is, you know, what it takes to sit with people, and the kind of training that we've had. I mean, we sort of take it for granted, I think, but because it's just been part of our lives. But the fact is that we did breathwork groups together for 10 years.
Yeah.
And that was, you know, mostly once a month. So we also worked with people that had dissociative identity disorder in Michael's practice. We worked with those patients together and saw people with psychotic disorders, you know. So the range of our experiences of being with people in these states that are non-ordinary. I mean, even people with psychosis, it's a non-ordinary kind of experience, but just that kind of experience, you're used to kind of holding the space for people. And
Yeah.
it's hard to kind of convey. And we've also had our own work. We've done our own therapy, and we were in the breathwork training, which it requires you to do your own work. We've had the MDMA substance together with a therapist back when it was legal. So there are just so many things that, you know, you really want people to have a framework of
Right.
their work.
It's from the outside, it could look really glamorous. People could feel like, oh yeah, I want to do that. But it really, I'm impressed by how much it demands of you as a therapist
Mhm.
to be there for another person and not be there for yourself, but for that other, at the service of that other person.
Yeah.
That's really not everybody suited for that, I don't think. And
Yeah.
but the challenge is you guys have so much experience. There's no way to keep replicating that.
No, but we are seeing, you know, younger therapists have very good results too. So
Yeah.
Yeah. Oh,
it's
good.
definitely,
Mhm.
you know, we don't mean to imply that
Yeah.
many other people aren't good at this. It's just that many people don't realize the amount of work it takes, and also how much the therapists need to do their own work in order to really be appropriately present.
Yeah. What about the whole thing of taking on somebody else's burden? You know, how do you process that in yourself to not get eaten alive by hearing of horrific things that happen in war, for
Yeah,
example?
yeah,
Mm-hmm.
yeah. Well, so we've had a few of the younger therapists in the phase 3 studies, although they're doing great, remark that, you know, as you say, it seems pretty exciting and sexy. And a few of them said, you know, this is really a lot more work than I realized. So, you know,
Yeah.
if you're going to invite somebody to go into these deep states for the purpose of healing, you got to sign on to support them through that, and that may be at times very challenging and take extra time and extra attention and extra availability.
Mm-hmm.
I wonder if a cadre of PTSD survivors, if you will, might also, some percentage of them might make excellent therapists for other people because they've been there.
I think
And
so.
we've got the models of support groups of AA and others in AA and all these other groups. That may be part of the solution of, you know, how do you get enough people out there?
Yeah, I think that's true. And we've had some people that have been in the studies who are psychologists or other therapists who are interested in eventually doing this kind of work.
Yeah.
That's great because they have been there.
And when you mentioned the possibility of group work, I realized then that the breath work is done in groups, right? People pair up
Yeah, yeah.
and you take a turn in each position.
Mhm.
And now is that marketed as therapy? It's not really sold
Not
as
really, no.
No.
Well, what Stan says, it's really a spiritual practice, and the therapy is a side effect.
yeah, yeah, yeah. Interesting.
Yeah, so the framework of it is more of what we've taken, you know, as the set and setting and the framework of having a male and female, although, you know, that's changing with all of the different younger people that are interested in doing it together as therapists. But, and then we've added our own trainings to it, our own therapeutic approaches, really.
Yeah. So I suppose I should ask you, there may be some people listening, watching who say, yeah, this is something I could do. I would like to do this. Uh, where do we send them, those people?
That's a good question. And, you know, for one thing, we're delighted when we hear young people or people early in their career who want to do this, because as you say, the need is so great. So it's very exciting that so many people are interested. It's beginning to change a bit in terms of training. We're getting approached by some major academic institutions wanting to start programs. And we're getting approached about some, others are happening in the psilocybin domain. So I think the main thing is to get good training as a therapist. You know, we train people how to work with MDMA the way we've been doing it and the way we need to sort of do it in all the sites for the studies, but we're not training therapists. So I think the first thing is for people to go where they're drawn. You know, if they want to get a PhD in clinical psychology, if they want to get a medical degree and be a psychiatrist, if they want to get a master's level therapy degree, whatever.
Nursing.
Nursing, I say nursing.
Definitely nursing. That's the number one.
Right.
You know, so get really good training as a therapist in general and do your own work. And so you'll be prepared to work with what comes up for you in these sessions. And then, you know, then there's the MAPS training program. But I also think in the pretty near future, there are going to be some more and more programs where people can begin in their regular therapy training, begin to incorporate this. The one that's already doing it to some extent is California Institute of Integral Studies. Janice Phelps has developed an amazing program there. It's outside of the regular curriculum, but it's part of CIS, so it's at an accredited institution. And we teach one at the week that Jonathan was there. That was, as you know, part of that. So that's a good route. Also, as the MAPS trainings increase, people can do that. And hopefully they can begin to go pretty soon to one of these universities that has a psychedelic training and therapy and research institute in the university. And there are a few of those in the works right now.
Yeah. I suppose in passing, I'd like to bring up Michael Pollan's book, which seems to have lit a bonfire.
It does.
Totally.
It certainly does. But somebody was saying, I actually saw him at the American Psychological Association recently, and somebody was saying, we call him the pollinator.
Great. That's wonderful. Wonderful. I thought of that. Well, is there anything more that either one of you would like to say to kind of wrap things up here?
Well, I think we always have to be thankful for the participants that have come through these trials and been on the forefront as well. You know, we've had some incredible participants who also have gone on to do work out there with people with PTSD, and yeah. So I want to make sure.
Yeah.
Yeah.
And they, you know, a number of them are actively doing outreach to try to help us get this approved.
Yeah.
And especially the veterans, but also other people. And I also want to, well, I've already really acknowledged Rick Dobbin, without whom none of this would be happening.
Yeah.
But also, we tend to be more public, so we get more attention. But the team that makes this possible is just an incredible team of people at MAPS and the MAPS Public Benefit Corporation, which is owned by MAPS. It's kind of a technicality, but it's an incredible group to work with all these years, and it's growing fast. But it's really bright, well-trained, dedicated people that are working extremely hard all the time, working for a nonprofit, so not getting rich from it. And I just want to acknowledge how what a privilege and how great it's been to be able to work with all of them, and how much we wouldn't be able to do any of this without the tireless work of all the people that are supporting it. As
Well,
of course.
I want to acknowledge your pioneering contribution to this, because I'm among that group of people that back in the 60s and 70s, felt like, wow, there's something so powerful and important here. And to do the groundwork that you're doing to move it into a legal sphere and a healing sphere is such an important step, and I know you've given your lives to it. So thank you for that.
Thanks. It's been really fun. And, we never set out to be researchers, but it really came from clinical need. We just finally decided this is not okay.
Right.
Coming to us suffering, and nobody's exploring these tools that we have reason to believe could be helpful. So it's been an amazing privilege for us to be able to do this, and it's kind of amazing where we are
and to be able to do it together.
Yeah. Okay. Well,
Thank
Michael
you.
and Annie Mithoefer.